So in this talk, I'm going to cover these topics, my approach to assessment, clinical assessment, and how to identify and analyze each component of the deformity, effect of distal tibial ankle deformities on the foot, so-called compensatory deformities, and how they surface as hidden deformities when you start correcting them. And I'm going to spend some time talking about radiology and how to incorporate that into your practice. For the last 4 days, you have been looking at long leg x-rays. You could get a lot of information by just looking at x-rays, whereas in foot and ankle, that is not possible. If an x-ray is shown to you, it'll be very difficult to work out what you're dealing with. So it's all the more important that you spend some time talking to the patient, taking detailed history, particularly emphasizing on what treatment they have had, non-surgical and surgical, and post-op complications. In history, I generally look for these 4 categories, and that's my classification from experience. So I put them into congenital, neurological, diabetic, and post-traumatic. That's how they work out. Why so? The congenital deformities have a predictable deformity pattern. For example, in CTEV, you know you're going to get a variable degree of equinus, hindfoot varus, cavus, and forefoot supination, unless someone has interfered, overcorrected the clubfoot. Similarly, congenital vertical talus and all those deformities. So you know where the trajectory is. Neurological is important because the deformities in the initial couple of years, up to 5-7 years, is mainly due to imbalance and not due to bone deformity. So it's important to understand that you balance the foot before start doing any bony work. So they are a different category. Diabetic feet have their own issues, and you'll hear a lot about it, so they go into that box. And the post-traumatic is interesting because, at King's, the trauma center, I see a lot of them. The problem is there is a lot more fire, it's a lot more smoke around a small fire. So they might have a minor deformity, but a lot of pain because there's a soft tissue component, there's a joint component, there's post-trauma reaction, edema, etc. So the deformity is less, but the noise is more. So even if you correct the deformity, you're unlikely to get good result. Okay, and expectation should be set at the very beginning, both by the surgeon themselves, their capability and what the patient is expecting, and alert always about smoking and diabetes risks. And clinical examination should follow. I do in a sort of ankle, hindfoot, midfoot, and forefoot. And while I'm examining them, I make a note of whether the deformity is flexible or fixed. And don't forget to examine the foot and the shoe wear, and also finish off with a neuromuscular examination and vascular examination. So I look at the foot this way. It's a beautiful structure, and all these blocks. So there's 4 blocks, and on top of it, the hidden block is this soft tissue. Okay, so the muscular imbalance, tight tendon like contracture, etc., and then start assessing the foot with that in mind. So here is a deformity, Charcot-Marie tooth. So there's the equinus component, there's varus, there's midfoot cavus, and severe supination. Of course, don't forget the toes. Whereas in this Burns contracture, young lady is mainly equinus at the ankle, hindfoot, midfoot, and forefoot are in good alignment. And then you say, well, how am I going to put these pieces back into this shape? And my priority is most rigid deformity, and the most deformed segment is treated as a first option. And the sequence within that is to do soft tissue release. So if you can get away with soft tissue release, stop there. And then do osteotomies as a second option. Like, for example, for equinus, you can do a calcaneal osteotomy and see how it works. Only as a last resort, I do joint fusions. And then acute versus gradual, depending upon how bad the deformity is, either use a frame or simply doing acute osteotomies. So now we move on to this. You might wonder why Newton's name is mentioned here, because he said in third law, for every action, there is an opposite and equal reaction. In foot and ankle, which is a closed linked chain, for every deformity in one segment, there is a predictable compensatory response. And why should we know about it? When the compensatory deformities are chronic, or response is chronic, they can become deformed as well. And you need to incorporate that into your treatment plan. So here you'll find this table in every textbook, in our textbook too. So for a varus example, for example, a varus lower tibia, ankle joint surface, the first response is eversion. And when it reaches to the 15 degrees, that's the normal joint range of movement, then the secondary response comes from pronation. Similarly, in valgus, and you can work it out. And remember these, keep them handy when you're correcting these deformities, because some of them can come back as hidden deformities. Similarly, in the foot, there is a very close sort of predictable response. When the heel is in varus, forefoot goes into pronation. And when the heel is in valgus, forefoot goes into supination. So you can imagine, twisting this towel, wringing out. And this is, anybody who wants to do serious foot and ankle should read this, every page of it. And why this is important, you'll see it here. And how do you find out where's the compensation deformity? You should know from that table where to look for. And how do you work out whether it's fixed or flexible? If it's flexible, you don't have to do any treatment for it, just physiotherapy. But if it's fixed, then you might need an osteotomy. And the best way to do it is to assess, again, clinical assessment. Radiology might help, but not always. So in this example, for valgus compensation, the heel is going to go into varus. And over a long time, these structures can become tight and cause permanent deformity. So you grab hold of the heel and do this opposite movement. If you can get good range of movement in the opposite direction, this is a flexible deformity and not fixed deformity. Why it is important? So look at this. If the deformity is fixed and you correct the valgus deformity, you suddenly unmask that varus of the heel. It's not correctable. Then you have to incorporate that into a calcaneal osteotomy. And this Coleman block test showing that the heel is correctable. This is a child, very correctable, whereas in an adult is fixed. So this is a fixed compensatory deformities. So now we move on to radiological assessment. Do not order an X-ray without doing a thorough history and clinical examination. It doesn't make any sense. And every foot and ankle X-ray should be weight-bearing. As much, if they can't weight-bear, go and do a stress view. So here is a patient I saw in clinic. She had a severe valgus deformity from post-polio paralysis. It was literally walking on the medial border of the foot. And I requested X-rays, and these came back. Okay, so when I asked her, she said, yes, I was made to stand, but they couldn't do my ankle X-ray, so I was lying down for it because it wasn't adding up with clinical exam. And then I sent her for weight-bearing X-rays to see the difference. And that's very, very important to take on board. If you didn't know clinically, you would be in trouble. And then have a method of getting this. It has to be reproducible. Talk to your radiology department, radiographers, spend some time. And you need to really get these consistent views. When you say foot AP view, quite often this is cut off here, and they're focusing on this. But it should be aimed at the root of the limb to get that. To be able to see talus and rest of the forefoot. Similarly, a good lateral view should be centered on ankle and not just a midfoot. And if you're doing an X-ray for equinus, and this is important to get this segment of tibia, preferably full tibia, but if not, at least half of the tibia. And patient pushing on it, really. And this is one view everybody should have in their armamentarium. Go and talk to the radiographers, and this is long leg calcaneal axial view. Anish mentioned Kobe view. This is, the new radiology students don't know what Kobe view is. This is called Salzman view otherwise. And you have to really make sure that this is how it is done together. This is like a long leg picture for your lower limb deformities. So you see the tibia, you see subtalar joints and deformities. And here is a talocalcaneal fusion for this. Well, let's get your books out. David, can you go through all these 33 angles and draw them? No, we are not going to do that. Because you don't need, we have laid out the most common ones in this book, so I'm not going to go through it. These are the common ones. Tibio-calcaneal relationship, I'll show some examples to illustrate the point. So this is a case of hindfoot malalignment. And that's a history, 30-year-old, chronic history of pain since teenage years, and he's a chef, unable to cope with it. On examination, fixed hindfoot. As you can see, it doesn't correct, too many toes sign, and a sort of flat foot or bean-shaped foot with forefoot abduction. So this is important for you to then analyze X-rays. So you want a lateral view, AP full weight bearing, and a calcaneal view. Let's look at this. So this is a sequence. On lateral weight bearing view, you're going to do two angles. This is a calcaneal inclination or calcaneal pitch. You might say, what's the importance of this? If this is, yeah, I can still accept it, but it tells you that there's something pulling on the calcaneum. So there's equinus component there, okay? That's why it's more horizontal. Then Meary's angle, or lateral talus first metatarsal angle, and the importance of this is to see where the apex is. In diabetic feet, you will see in mid-tarsal joints, whereas in this, where the hind foot is the main driver, the apex is here. So there's no point in doing mid-foot osteotomy to correct this angle. So that's important. So on APV weight bearing, it shows clearly the magnitude of forefoot abduction and talonavicular uncoverage. And this is the most important view. This tells you how deviated it is and how to plan it to get it back. So this is, if you have to really bring back one angle to correction, and this is the one to focus on. So the normal angles here is there is a normal talocalcaneal distance. That means the center of the calcaneum is 5 to 8 millimeters lateral, and it is in slight degree of valgus. That gives you a plantigrade, pain-free heel. So this is important to reproduce this relation with whatever surgery you plan. So we go back to our rules. So this is Cora here, tibial axis in red, in yellow here, and they're meeting somewhere superior to the subtalar joint. And we can only do this correction by doing a calcaneal osteotomy. So it's rule number 2, okay? And what you need to control is how you displace this, because we want to get this relation, yeah? Remember that, those numbers, yeah, within 1 or 2 millimeters of that. So I did a calcaneal osteotomy, shifted it, and you have to do a calcaneal axial view while you're doing this procedure. And that's the end result, near, I think, within 1 or 2 millimeters of that. I'll come to that wire in a minute. So now go back to the AP view. Lowered calcaneal pitch corrected by my shift osteotomy. And the forefoot abductors by doing a calcaneal lengthening procedure here, and that will swing the entire foot through talonavicular joint, resulting in collinearity. Okay? And this is the end result. Heel valgus coming back to neutral, and that medial sort of bean shape corrected. So now hidden deformities. They are hidden because you won't realize this is going to happen. But you have to know this. You have to really understand what can be a hidden deformity. And if you go back to that table, it will give you the list of all the deformities which could unravel as you're correcting the primary deformity. So here, this patient had this equinovarus deformity from a compartment syndrome. He had an open fractured tibia, and it resulted in this compartment syndrome. You can test these. It wasn't looking bad here, but I was aware that it would be a problem. Either you can take a pre-emptying sort of measure by doing flexor tenotomies. I used to do that, but I'll tell you, it is very unhappy when they come back and just say, well, I can't really grip my slippers or my clogs in summer because I don't have flexion power. And that's really, you can't do anything about it, okay? So you have this conversation with the patient, and this is what I was telling you about setting their aim first. So I told them that this will happen, and we'll decide then. But I'm sure there are as many of my colleagues who would have done flexor tenotomy here or pinned them beforehand. So and I over-corrected this foot, bringing it to, this is my butt frame, and that's a heel neutral, and this started happening. So I knew this was flexible under GA. And so I really, explained to him that this will work out, if not 6 months down the line. Don't just say in a couple of weeks. It takes that much of time. And that is without a single flexor tenotomy. And that's after 6 months. So you can decide what to do and how to deal with these. But be aware of it. That's more important. You alert the patient. Some say, well, I don't like this, do it. Yeah, I'll go and do flexor tenotomy. But I alert them that they'll be straight but floppy. Here is another case, and slightly more sort of interesting in the sense that this gentleman had this posterior apex deformity. And you would know from that table that the compensation for this would be an equinus deformity. That is not obvious here at all. If I said this is an equinus, you won't believe it. But the clue is this sort of anterior subluxation, and it's becoming arthritic. Foot and ankle surgeons only do foot and ankle, would say, and go, let's fuse this. But if you fuse this, and with this deformity left, they will soon get knee pain because the secondary compensation comes from the knee. So if you just see this, so once you correct that deformity, you're unmasking the equinus deformity. But I knew this won't work with physio because there's a lot of orthotic changes. So I just said at the second stage, I'll give him a good 6 months. If it doesn't correct, I'll come back and fuse it. So that's my straight tibia. And you can see I unmasked the equinus deformity. I came back later because it was painful and did ankle fusion. So to conclude, it's very important to understand the deformity fully to create a functional foot. And I spent a lot of time in history and examination, understand primary and compensatory deformities, and work out how to differentiate between them and try and create as normal, not necessarily all the angles should return. If you're focusing on one angle, that's a talocalcaneal angle that you need to restore. Thanks.
Great talk, thank you.
Thank you.
For that last case that you presented, what was your rationale for staging it, rather than doing both levels at the same time?
The easy answer is my age. I've seen enough mistakes doing them all together. So when you do that, it's very difficult. So give him some time, and you'll be surprised sometimes, like those toes. I won't suddenly rush and do flexor tenotomy. 6 months he worked with physio, and it got out. I could still end up doing flexor tenotomy. So yeah, stage, particularly when you don't know how that foot is going to behave. Yeah, so if you have time, I know you work in different parts of the world where coming back for surgery is a problem. Yeah, you could go, but that's a bit too much in these cases. Yeah, I've learned it from my mistakes. So,
Alwyn's got a question.
Just a question about intraoperative Saltzman view. Could you just describe how you do your intraoperative?
Sorry?
Your intraoperative Saltzman view. You mentioned doing that with your calcaneal osteotomy.
Oh, calcaneal osteotomy. It's axial view again. You should try this before draping the limb. Get the radiographer to do it. Bring the heel right down and incline as if you're looking into the heel. So it will be a calcaneal axial, not long leg. Preoperatively planned it, you know how much to displace. So that was 5 to 8 millimeters.
How do you do an intraoperative Saltzman view?
That's what I'm saying. It's a calcaneal view. It's a calcaneal axial view. You can't do all that. So you should plan it how much displacement you need beforehand by doing those calculations, how much calcaneal displacement you need. So you can only get an axial view of the calcaneum. You can't get Saltzman's view there. So you should have all the planning, and you say, I'll lateralize it or medialize it by certain millimeters.
Do you mean like where do you bring the C-arm in from? How do you position the patient? Yeah.
Yeah. Okay. So make sure that the patient is on radiolucent table and practice that with the radiologist before you do it, before you drape it. So it comes from, the X-ray comes from the heel. I'm sure Hemant is going to talk about it, but I can show you later.
Thank you. Any more questions? No.